All right, guys. So for this lecture, we're going to take a look at the disorders of the respiratory system and take a look at all of the different issues that we can see and try to talk a little bit about some of the ways to try to fix some of those issues. So let's go ahead and start. The first two here are the kind of the opposite of each other. So we have hyperventilation as well as hypoventilation. You can find them on page 460 in your textbook if you want to take a little bit more of a look at them. But hyperventilation simply is increased respiration rate. When that happens, you got a couple things going on. So obviously we have short, rapid breaths because if we have hyperventilation, they really can't breathe completely in those cases. What this actually does is it moves more oxygen than it really needs. So as the oxygen builds up into the system, we see a drop in CO2. And then this increases exhalation. The problem that really ends up here is this results in an issue of alkalosis. So we have a higher pH in the blood. And if we don't treat it, it can lead to apnea, so the cessation of breathing, or cyanosis, kind of a bluing, because there's too much oxygen in the system and it won't really kind of, we're not able to kind of balance that, the diffusion back and forth. Simple solution for this: if you get somebody who's hyperventilating, you can ask them to breathe into a bag. Rebreathing their own CO2 then brings down the pH level and kind of brings everything back to normal and should regulate their breathing level. Normally, what will happen here if they don't, they're going to end up probably passing out from the apnea, from the cessation of breathing. They should fairly quickly start to rebreathe on their own, but in some cases that doesn't happen, so we need to make sure that we try to treat that as quickly as possible. Hypoventilation is then the opposite, obviously. So we have really slow breathing, and because of the slow breathing, we have an increase in carbonic acid, which is essentially an increase in CO2 in the blood. The only real way to fix hypoventilation is to essentially give people 100% pure oxygen via a nasal cannula. And then allow them to breathe on that air, which should result in bringing the pH back up and kind of evening things back out. Next one we have is what's referred to as emphysema. Emphysema is a destructive disorder in the lungs where the alveoli start to enlarge, and then the little walls that go between the chambers of each alveoli start to break down. Because of that, one airway kind of leads into the next airway, and over time, those airways start to collapse on expiration. So when they exhale, that airway collapses in on itself, and then the patient has to use a huge amount of essentially muscular force to not only breathe out but also to breathe in. And because of that, these people end up with kind of this, what we refer to as a barrel chest. You can see that down here in the picture. So this would be normal. This is what would be referred to as kind of a barrel chest because of the overuse of those muscles that control the lungs, especially the rib cage as well as the diaphragm. Patients are sometimes often referred to as what's called the pink puffer, because they usually have somewhat of a pink appearance because they're laboring to breathe. And then it can be brought on by a couple of different things. So it can be brought on by chronic inflammation, which essentially promotes this kind of fibrosis of the lung tissue, this stiffening of the lung tissue. And then in late stages, we usually see these people become cyanosis. Again, they have this kind of blue tint to them because they're not perfusing oxygen well enough. And again, it's because of the collapse of these alveolar sacs, and we're not being able to get oxygen down into those. Another one that kind of goes with that is chronic bronchitis. So this one is an inflammation of both the mucosa, and then it also impairs ventilation of gases because we have an inflammation of that mucus lining. These patients are often referred to as blue bloaters because they look hypoxic, meaning their skin has somewhat of a blue tinge to it, specifically their nail beds, lips, around their nose and eyes, and it's because of the increased carbon dioxide in the system. These people are really hugely at risk of lung infections because of the inflammation of that mucous membrane. They most commonly have pneumonia, so the kind of the inflammation of the lining of the lungs itself. And then they obviously are going to be hypoxic and cyanosis kind of early on because of these. I will say, we're going to talk about asthma here in a second, and asthma a lot of times in this will get confused. So chronic bronchitis isn't the irritation of this, it's simply the inflammation of that airway. And usually this is due to secondhand smoke, smoking themselves, and then they usually have some other issues on top of that, okay? Another one that we see is chronic obstructive pulmonary disease, or what's referred to as COPD. This is kind of exemplified by people who have both either chronic bronchitis as well as emphysema. It's one of the major causes of death in the United States. And what you can see here is you just have an excessive inflammation of both the bronchiole itself as well as a breakdown then of the alveolar membranes. Big features of this disease: patients usually have some sort of a history of smoking, which leads to the chronic inflammation and then the breaking down of the alveolar. They have really heavy breathing, which we refer to as dyspnea. And then it becomes more progressively severe as the disease processes. Coughing, they usually have a pretty significant cough, frequent pulmonary infections. So these people are in for a lot of respiratory infections. Other features that we see, most of the patients are containing high amounts of carbon dioxide, which leads them to be hypoxic. And then they have respiratory acidosis, so they have a low pH level because of the increased CO2. Those infections ultimately lead to respiratory failure because parts of the lungs start to kind of die off and become scarred, and then they have really big issues. Usually people with COPD are going to probably end up with some sort of a lung transplant at some point in their life. Big things here for chronic respiratory. I'll pull this video for you guys. We see a couple of different things. Just tobacco smoke and air pollution cause this. Continual bronchial irritation and inflammation will lead to the chronic bronchitis. And then if we go the other direction, we have a breakdown of the elastin inside of the lung tissue, which is the emphysema. Those two on top, again, then always cause this airway obstruction. And then at some point in time, we're going to get to a point where they can't move air at all anymore. Okay. Another one we see is what's referred to as sleep apnea. This is the cessation, or essentially the stopping of breathing while people are sleeping. This is usually due to some sort of obstruction, either soft palate or it could be because of the tongue itself. All right. So you can see in this case, this is normal breathing. The tongue's relaxed. Both airways are open, both nose as well as mouth. And in the case of sleep apnea, the tongue occludes, or the soft palate in the back of the throat can occlude that. The only real way to cut it, it can become problematic because then this continues to become an irritation and continues to be a problem. Obviously, also they're stopping breathing in the middle of the night. These are usually people who are heavy snorers, tend to be kind of overweight in most cases, and one of the easiest ways to fix that is through what's referred to as a CPAP machine. So a CPAP machine is just a continuous airway machine that keeps that airway open. Because it never really allows for this kind of relaxation of the tongue back against the throat. Right. Other ones we see are cancers of the lungs. So these are just abnormal masses that tend to develop in the lung. Problem with that is because lung tissue tends to turn over pretty quickly and regenerate. We tend to see these types of cancers to be really aggressive, and they can metastasize, meaning they move to other parts of the body. You can see the numbers here. They account for about 1/3 of all cancer deaths in the United States. We see an increased incidence in people who smoke. We know that there are lots of substances within smoke, tobacco, nicotine, tar, and all that are carcinogens. And then there are three basic common types. We have what's called squamous cell carcinomas. Those would be just kind of at the basal layer, adrenocarcinomas, and then small cell carcinomas. They can all be kind of problematic that we have inside of the lung. All right. This just shows you real quickly a video, the difference between a smoker and a non-smoker. What you're going to end up seeing is that the smoker lung does not tend to inflate fully, whereas the non-smoker should inflate fully and properly. I'll post that video as well. Just another one that kind of shows kind of the effects of that. Again, it's another one I'll kind of put in there for you guys. Another one that we see mostly in infants is what's referred to as SIDS, or sudden infant death syndrome. And this is just a stop or cessation of breathing while the baby is sleeping, which results usually in death. Some cases are thought to be some sort of a problem with neural respiratory control, and there really is no way to fix that or to know that that's going to happen. It just kind of takes on its place. But a third of the cases appear to be due to normal heart arrhythmia abnormalities, where they just don't tend to breathe, or because of positioning for the baby. So the big thing now is that we really want to lay that baby on its back, nothing around it, no blankets, no pillows around the outside. We don't want to lay them on their stomach or their side, which can be kind of problematic in most cases. Okay. Asthma then, is a little bit different. So asthma is chronic inflamed hypersensitive bronchial passageways, and these are usually due to some sort of irritant, which is different than the chronic bronchitis. Chronic bronchitis is kind of that inflammation of that airway. This one is inflammation due to an irritant that this person is exposed to. Usually these respondents have some sort of dyspnea, obviously cessation of breathing, they cough, and they wheeze, and you can see we have a kind of an asthmatic airway during an attack. So they constantly have this kind of narrowed airway, and then during the attack, it gets even smaller. We can give medications for that. There's lots of different inhalers that have different substances in them that essentially relax those muscles in the airway, and that's one of the ways to kind of treat it. Okay. Really quickly, developmental aspects of the lungs. So when we're in utero, all right, our lungs are actually filled with fluid. And then the lungs are not actually inflated with air until 2 weeks after birth because they're still trying to process some of that fluid that can be within the lungs. The surfactant, that chemical inside the lungs that helps kind of hold that surface tension, is actually not present until late fetal development, which is why premature babies really have a hard time breathing and they have to be kept in the hospital on a ventilator for such a long period of time, is because we're waiting for that surfactant to kind of come online before we can kind of discharge them and get them to go home by themselves. Other important effects that we see here, we have birth defects that we can have. Cystic fibrosis is one of those. So this is a genetic disorder where the infant has a really heavy mucus secretion inside of the respiratory system that can cause problems. Obviously, it will not allow them to exchange air. And then they have usually a pretty good cough. And then another one is a cleft palate. So this is an opening in the hard palate and usually on the top of the mouth. Usually extends outward and kind of involves part of the lip. And in those cases, kids don't exchange air real well because there's an opening essentially between the nasal and oral cavities. Other ones real quickly just to kind of go through. So we talked about cystic fibrosis, just to give you a little bit more information. So this is that oversecretion of mucus in the lungs. It's one of the more common lethal genetic disorders that we have in the United States. And it really kind of impairs food digestion because they a lot of times will cough a lot of this mucus up and then swallow it down into the digestive system. And then as well as the digestive system tends to produce more mucus. So we just don't have absorption is one of the big things there. Another one we see is infant respiratory distress, or IRDS. It's common in infants who are born prematurely, and again, it's due to that surfactant production. They just don't have enough of it yet. Infants in those cases experience dyspnea, and then within a few hours, after a few hours, they're expending a tremendous amount of energy to inflate their lungs, and then that some cases can cause a lung collapse. Other injuries that we can have to the lungs are pneumothorax. This is a collapse of lung due to air in the interpleural space. Usually it's caused by some sort of a hole or opening in that. So either a puncture wound or a rib break that causes a puncture into there, and it decreases that negative pressure that we have, so the lung collapses. So the way to fix that is to insert a chest tube that will drain the air out of that cavity or space, allowing the lung to reinflate on its own. And then over time, we can remove that chest tube as it seals itself up. You can also have a spontaneous pneumothorax where essentially this lining just isn't very thick, usually due to some previous injury, a rib fracture or something else that didn't completely tear it. And then all of a sudden we get this kind of opening of that airway. Other aging effects that we see, as we get older, the elasticity of our lungs decreases, which in turn decreases our vital capacity. Also, we're going to see a decrease in oxygen levels. And then the stimulating effects of carbon dioxide don't have as great of an effect. So we don't tend to increase our respiratory rate, even though we don't have enough oxygen. And then we could also be more susceptible to respiratory tract infections because we're not producing as much mucus, we're not getting as much air movement in and out. And all of those things can kind of create that. Respiratory rates, real quickly. So obviously newborns have a higher respiration rate than everybody else. They have smaller lungs, not able to exchange oxygen as quickly because of that. Newborns are somewhere between 40 to 80. Infants should be about 30 respirations a minute. Somewhere between a little bit over age 5, it goes down to about 25 respirations a minute. And then as an adult, fully functional lungs, you got 12 to 18. And then as we get older, it goes the opposite direction. We start to increase breathing because we don't exchange air as quickly. And we see some of those big issues. Big thing for this lecture is the disorders. So make sure you take a look at those. I know one of the big questions that kind of always comes up and people miss is the difference between the chronic bronchitis and the asthma. Asthma is an irritant causing that. Chronic bronchitis is simply just a inflammation, a chronic inflammation of those airways, whereas asthma is always some sort of irritant that causes that inflammation. Okay. All right, we'll go ahead and stop there. That should finish up lecture. We'll talk a little bit about things tomorrow. Get ready for the assessment.